Today what I really want to talk to you about is the health insurance marketplace, which is the specific feature that's mentioned in here that begins in 2014 that's getting the most attention, I think, in terms of the implications of the law. And I think it also really offers funders in Arizona opportunities on how you can sort of plug into some of the work that's happening on the ground in Arizona. So let me tell you a little bit first about the health insurance marketplace, elaborating a little bit more on what you just saw in the video. So the whole idea of the health insurance marketplace, it's been around for quite some time. Actually, the Heritage Foundation was one of the creators of the concept way back when, I believe in the 70s, and it really gained a lot of attention when Massachusetts health reform law was put into place. It's really this idea of being able to easily compare different health insurance packages and make sort of competition between different coverage choices available to consumers who might otherwise be squeezed out of the market. And so the marketplace is this online site for individuals and small businesses to compare and purchase coverage. And it's the exclusive mechanism by which you can get federal subsidies and cost-sharing limits on coverage beginning in 2014. So, the video talked a little bit about these tax credits that individuals may be able to get through health reform. You can only get those tax credits by purchasing coverage through the health insurance marketplace. You'll hear sometimes people refer to it as the marketplace or the exchange. The feds are really trying to brand it as the marketplace these days, so I will try to use that terminology because that's what you'll be hearing more and more of. The marketplace will open for business on October 1st of this year, and the open enrollment period will extend through the end of March. In subsequent years, the open enrollment period will be much shorter, so it's a long enrollment period for this first year only. And one of the reasons we think as funders that it's worth paying attention to the marketplace is that it's estimated that 1.3 million Arizonans are predicted to eventually receive their coverage through the marketplace. So this is a big deal. And so something that you really need to pay attention to if you're either working in health or working with families in Arizona. So let me talk a little bit about who's predicted to use the marketplace. Estimates in this state are that almost 500,000 Arizonans are going to be accessing coverage through what's called the individual exchange, which means they'll either be buying insurance just for themselves or for their families, not businesses getting coverage. And then there will be about another 343,000 people who will be getting coverage through the exchange that'll be Medicaid coverage, and this is through the Medicaid expansion and restoration that you've heard about a lot in the news recently. So as you may remember, Arizona is one of the states where we now have a law that basically is saying that we agreed to increase eligibility for Medicaid up to 138% of the federal poverty level, allowing this 343,000 additional individuals to get coverage. So the remainder of the people of that 1.3 million who will be getting coverage through the exchange will be getting it through small businesses. And this is called, you'll hear it referred to as SHOP. It is a small business part of the exchange. And so what mostly I'm going to focus on today is the individual coverage and the Medicaid coverage that people will be accessing. So in Arizona right now, there is an effort to start educating folks about the opportunities through the exchange, both in terms of organizing outreach efforts and also enrollment assistance efforts. And I'm going to talk a little about those efforts. There's a coalition that's being formed called Cover Arizona, and the coalition really builds off of the success of efforts that have occurred over the past few years to enroll people in what's called the pre-existing condition insurance pool. The pre-existing condition insurance pool was also formed out of health reform law, and Arizona was actually the most successful state in the country in terms of covering people. We covered over 4,000 individuals, and these were people basically with catastrophic health care needs who were able to get into this high-risk pool and pay a premium for coverage. beginning in 2014, that pre-existing condition insurance pool will go away as part of the health reform law, because the health reform law anticipates that those people will transition over to Medicaid or to private health insurance through the exchange. So this coalition was formed with a variety of organizations that did outreach for the pre-existing condition insurance pool. And today, this coalition is really the basis for efforts being organized to do outreach for Medicaid as well as for the exchange moving forward. And the coalition has around 200 members right now. I say around that because it's like any sort of movement that's beginning. People come in and out. You're not even sure who's in and out at any one time. But really the goals of the coalition are to maximize enrollment of individuals and families in the new insurance marketplace in Medicaid, and to really sort of figure out what's working or not working. Yeah, please.
Who's in that coalition? What's the, if you were to profile what kinds of organizations are in that coalition, what would that be?
Yeah, let me get to the next slide and I'll show you. But that's a great question. So, perfect timing. You set me up, right? So the coalition has around 20 to 30 steering committee members, and then they have a broader group that is organized in terms of regional coalitions where people call into calls to get updates, and that's really the broader 200 that I referred to. But the steering committee itself is comprised of these organizations, so SLHI, St. Luke's Health Initiatives, Chicanos Per La Causa, Keogh Health Connection, the Alliance of Community Health Centers, Maricopa County Department of Public Health, Children's Action Alliance, Area Agency on Aging, Regional Center for Border Health, Valley Interfaith Project, Promise Arizona, Enroll America, Young Invincibles, Simpatico of Arizona, Arizona Hospital and Healthcare Association, People of Color Network, Dignity Health, Arizona PERG, Pima Community Access Program, Arizona Council of Human Service Providers, North Country Healthcare, and Ryan White Program. So it really, the attempt is to try to have a wide variety of kinds of groups to be able to touch different types of organizations, different constituencies. But the coalition basically is open to anybody who wants to be part of it. So the steering committee has really been organized to try to figure out how to best conduct outreach to a wide variety of groups and touch them. So let me talk a little bit about how Cover Arizona is organizing and the work that it's doing currently. So to try to conduct outreach to 1.3 million Arizonans is no small task. And what we know is that by looking at past efforts such as the implementation of Medicare Part D or any new programs such as Kids Care when it began in the state, it takes a lot of work and it takes a lot of organizing, and it also takes an effort to be very strategic in the work. So Cover Arizona is organizing really 3 different ways. First, by looking at demographics. Second, by organizing by geography, and finally by strategy area. And what I want to, so some of the things that they're thinking about when they're thinking about outreach to specific groups in Arizona is they want to make sure that people that they're touching include those who are currently uninsured, who have been served by our healthcare system in the past. So, for example, we know that over the past few years, we've lost about 170,000 people off our access program due to some state budget cuts. And we want to make sure that those folks, for example, regain coverage. We know that we've also lost coverage for people with behavioral health needs due to funding cuts. So we want to make sure that those folks are targeted in terms of helping them regain coverage. We're also looking at strategies to help touch those who we know are uninsured in specific demographic groups. So looking at data to figure out who those people are is very important. And we also want to make sure that we're touching people who have a real need for affordable, quality health coverage. So we specifically know, for example, that older adults often fall in that population. They're folks who often have significant healthcare needs and have been priced out of the market from insurance coverage in the past. We also want to pay attention to changes that are occurring in 2014 that are going to affect health insurance in general. So one example is I talked about that pre-existing condition insurance pool. All those folks, that 4,000 some folks, will no longer have coverage through the pre-existing condition insurance pool, so they need to be transitioned over. In 2014, we also know that kids care as we know it will go away. So those folks will have to be transitioned to Medicaid or to the exchange. We also know that there are new opportunities, for example, for Medicaid in terms of Medicaid expansion. Another factor that's being considered in developing strategy for this coalition for outreach is how to balance risk. And what I mean by that is the exchange is really an effort to try to be able to sort of pool health insurance so that it's more affordable for everyone. So if we only conduct outreach to those with significant healthcare needs, guess what? The average cost for coverage in that pool is going to be really, really expensive. So we think as funders it's really important for us to think about how do you get sort of healthy people into the exchange to make it successful over the long run.
I have a question for Kim.
Yeah.
This is Tony, for those of you on the phone. On the first bullet, I'm confident that immigration reform is going to go through. I mean, we will not be happy with the final piece of legislation, but I know something's going to happen. Mm-hmm. Have you taken into account that population that will become eligible once immigration reform goes through?
Well, that wasn't taken into account into the 1.3 million Arizonans, no. What you do have is with the exchange right now, legal immigrants are actually qualified for subsidies and can purchase coverage through the exchange. But in terms of the implications of immigration reform, that's not reflected in these numbers.
Because you know it's going to have an impact on
Yeah,
Bullet 1.
no, it
We have
would.
thousands of folks who are in
You're right.
Bullet number 1.
And that's actually been one of the challenges, is I think sometimes in messaging on
Thousands, millions.
Yeah,
No,
yeah.
well, I'm talking about the state.
Yeah,
State, but
yeah.
one of your members, you know, Petra from Promise, Arizona, probably
Right.
has some estimates. Some
Yeah.
of those groups.
Yeah. No, there. Lisa Urias is also one of our board members who's definitely paying attention to that. So let's talk a little bit about who the uninsured are in Arizona. So we know that it's somewhere around 16% of Arizonans are uninsured. This data comes from the Arizona Health Survey, which was last conducted by St. Luke's in 2010. And the uninsured skew a little bit more male than female, and not surprisingly, they tend to be younger folks rather than older folks. Although we also know from the survey that among older adults, they are often the people who can least afford coverage, right? So you have to sort of keep both in mind. And we also know that the people who are uninsured are more likely to be Hispanic or Latino, followed by Black or African American, than Native American or American Indian. So there's definitely racial and ethnic disparities in terms of coverage in our state. What you see here is actually a graph of where the uninsured are concentrated in Arizona. And the dots are actually rates of uninsurance by county, but the bars are number of uninsured by county. And not surprisingly, you see Maricopa County standing out. It's just because we have more folks, right? We have lots more people. So you'll see, for example, Santa Cruz County has a very high rate of uninsured, but they just don't have that many people living there. So it doesn't show up as high in terms of the bar chart. And we've also been able to look at data getting down to a zip code level. So what we know is that the folks in Arizona who are uninsured are often concentrated in very specific geographic areas. So here, for example, you see that the #1 area where the uninsured reside is in a zip code area in Yuma, just concentrations of the uninsured. And all of this information really helps inform how outreach can be done in a targeted way. So let me turn now to these two different charts The first is a flow chart, and the second is a series of boxes. So we'll talk a little bit about what's happening in Arizona in terms of organizing for health insurance outreach and enrollment assistance. So first of all, let me start with the boxes. Based on the data that's been collected by the Cover Arizona Coalition, they're looking at a number of different types of strategies and targeted approaches to different types of groups to help get people covered in our state. So the first approach is really focusing on low-income kids, families and kids. And Dana Neymark from Children's Action Alliance is taking the lead on this approach. And here it's really focusing on those kids under 19 who are currently enrolled in coverage or maybe able to get coverage for the first time through Medicaid expansion and through the exchange. And what we know is that there's going to be a lot of things going on for kids and families in 2014. So like I said before, sort of kids care as we know it is going to be going away. There's going to have to be a lot of transitioning of kids between kids care and programs such as Access, which will be expanded, and the exchange. There will also be a lot of complicated eligibility decisions for families. So you might have a kid, for example, who qualifies for the exchange or for Medicaid, and a parent might qualify for coverage through the small business, and making determinations on where families can best benefit from coverage are going to be complicated. So getting information out for kids and families is going to be challenging. And so this is really looking at specific strategies not only to reach that information, to provide specific information and assistance to those families. The second group of strategies is really focusing on the young adult population. And again, the reason for this group is we happen to know that they're the folks who are most likely to be uninsured. And they're also the healthiest. So if we want that balance for school, we really want to make sure we do outreach for them. And so this is actually where St. Luke's Health Initiatives is making a series of investments. We are contracting with two different groups. One is called a national group called the Young Invincibles that's already organizing in Arizona. And they're focusing specifically on outreach to the young adult population between the ages of 18 and 34. And they're going to be focusing a lot on college campuses and community colleges, primarily to do their work. And we're also contracting with a local group called Arizona PERG, who has relationships at campuses to work in tandem with Young Invincibles to conduct outreach. So we think this group really merits some focus, and we didn't see anybody stepping up to the plate to focus on this specific population. So St. Luke's Health Initiatives thought it was a wise investment to focus on outreach for this group. The third group we call sort of loosely the diversity group, and it's really looking at strategies based on cultural or racial minorities and targeting those efforts in those areas. It's primarily focusing on the Latino population, but there are also other populations. So for example, there's strategies on how do you reach refugee population. And the leads in this area are Daddy O'Connell from Chicanos por La Causa, Sandra Johnson from Keogh Health Foundation, Michael Goforth from the Pima Community Access Program, and Cherry Tomlinson from MIHS. So they're developing a variety of strategies to reach this population. The next group is sort of the older adult population, and these are, again, strategies really aimed at reaching sort of that baby boomer group that hasn't hit Medicare age yet. And Glenn Spencer from Area Agency on Aging is taking the lead in this area. He's working actively right now with AARP on these strategies.
Can I ask on the group before?
Sure.
Just remind me on the Native Americans, where are they with the ACA? Are they out of separate?
No, they're in, they are exempt from the individual mandate, so they don't have to buy coverage, but they can certainly buy coverage through the exchange with a subsidy. So you're right, that's a group that has to be reached also.
Do the 38% of uninsured African Americans, do they fall in the diversity group?
They do.
Okay.
The next group is people with chronic health conditions. And I should say all of these groups, you'll obviously see there's going to be overlap between groups. I mean, people none of us fall into a box, right? We all fall into multiple boxes, but we wanted to make sure there were targeted efforts in a variety of areas. So this is really folks with, chronic conditions who have just really need health coverage and trying to make sure that they are reached. So this would include the people who are in a pre-existing condition insurance pool currently, but also groups that are touched by organizations such as the Cancer Society or people with Ryan White Program, people with AIDS, the Heart Association, trying to look at sort of those chronic disease groups and how do you do outreach through those types of organizations. So that's really looking at sort of by demographics or characteristics, but we also thought that was appropriate to have sort of another cut thinking about organizations that touch people. So community health centers touch a lot of Arizonans, and so how do you conduct outreach through the community health centers, both in reach in terms of the clients they serve, but also using their own staff to conduct broader outreach. Hospitals are certainly another resource. So how do we make sure that hospitals are getting the word out to their patients and their staff? Behavioral health providers and consumers. We again know that a lot has happened in recent years in terms of cuts to coverage. How do we sort of make sure that through the behavioral health community we have organized efforts to reach consumers with serious mental illness or other behavioral health needs? And then finally, it's sort of an add-on, but it's important, is that small businesses are certainly part of all of this. I mentioned before that outreach for the small business, the shop, is sort of somewhat separate, but we also know there needs to be some coordination between this, because oftentimes we all live in families where some member may be part of a small business, so we have to sort of understand how those outreach efforts are occurring.
Kim, is Local First tied in somewhere at the small business?
Not yet. Right now, it's the lead on that one is Diane Brown from Arizona
Right.
PERG, and she's been working with the Arizona Small Business Association. So
And that's for-profit and not-for-profit.
correct. And I should say for the community health centers, the Alliance of Community Health Centers is taking the lead. For hospitals, Mary Sue Garganta from Dignity, as well as Debbie Johnston from the Arizona Hospital Association are taking the lead. For behavioral health, it's Emily Jenkins from the Council of Human Service Providers, and for small business, again, per Diane Brown. So we've sort of done a cut by demographics and organization type. We also, based on the original organization model for outreach for PSIP, also know that we have to sort of think geographically in terms of outreach. I know, it's my natural tendency is, unfortunately, to always start with Maricopa County. I mean, it's ingrained in me. I wish I wasn't, but it is. And so we have folks around the table from different parts of the state who are always saying, what about, this part of the state, which is good. I mean, it's really helping folks remember that there are different parts of the state we need to conduct outreach for. So first of all, the Central Arizona Coalition is led by Terry Tomlinson from MIHS. The Southern Arizona Coalition is led by Michael Goforth from the Pima Community Assistance Program. Western Arizona Coalition is led by Amanda Geary from Regional Center for Border Health. And Northern Arizona is being led by Tammy Howell from North Country Healthcare. So it's really helping us try to remember to make sure that we have representation across the state. So that's how the efforts are being organized, and strategies are being developed in each of those areas. They're building up coalition members for each of those areas. And then there are calls, for example, for the regional calls, there are calls once a month to be able to have the broader coalition understand what's happening. So let me talk then a little bit about how overall efforts are happening in our state in terms of organizing for the exchange. And this is really sort of a conceptual model that the Cover Arizona folks put together. And to me, it just is helpful in sort of thinking about all the work that needs to be done and where you might want to plug into it. So first, broadly, we know that we've got 1.3 million Arizonans who might qualify for coverage through the exchange. And what we know from polling that's been done is that almost nobody knows anything about this thing. They don't know it exists. They don't know it's coming. A lot of folks in national polls that have been done think that health reform actually was repealed. So there's a lot of educating to be done about just what's ahead of us. We also know that a lot of people don't even know that they really need to have insurance or should have insurance. So there's just a lot of education that needs to occur. So there's sort of this community awareness media effort that needs to occur. And what we know is nationally, the feds are going to be putting in some significant dollars into this. I don't know how many dollars, and I don't know exactly what the campaign might look like, but I know it's coming. And we anticipate that the brunt of the big media push is going to begin in October. So it's on its way. We do know that already the federal government's established 2 websites. One is called healthcare.gov, where consumers can go for information on the health insurance exchange. And there's another website called marketplace.cms.gov, where organizations conducting outreach can actually go for materials to be able to educate the community about the marketplace. So it's everything from downloadable flyers, posters, videos, scripts, the whole 9 yards. So you can get all that there. But no matter what happens, we know that as much as the feds may do all this education, there's going to be confusion on the ground in Arizona. So we think that there's probably going to be a need for local media efforts, local talking points, spokespeople on the ground, and certainly there's a need for presentations to communities and organizations in our state. And we know that we've already been receiving a lot of phone calls for our presentations, so we're setting up a speakers bureau working with the partners as well as with the Arizona Public Health Association. They've agreed to help get do a train-the-trainer to get people trained to be able to do presentations in communities. We just got a call today from Access who said they're getting tons of people they're going to start sending our way. So there's a lot going on in that area, and we think it's a real need. So first of all, you have this broad community awareness effort. Secondly, we know that there's going to have to be sort of outreach efforts in general. So the targeted approaches that I referred to before to reach people, because we know, people don't move on issues such as getting health coverage just through hearing a TV ad. Often it takes a person connecting with them or an organization they trust, communicating with them to actually make something happen. So here we see these demographic-based efforts that I referred to before, the geographic-based efforts that are also part of sort of those boxes that I discussed. And then finally, we have what are called targeted grassroots-like efforts, and I'll talk a little bit about that. There's a national organization called Enroll America that you may be hearing about, and they're beginning to have a presence in Arizona. They've hired 2 full-time staff already. And what they're doing is they have sort of a campaign-like effort to reach people about health coverage. So they actually have a database that enables them to do micro-targeting of people who are likely to be uninsured. So they can actually go down to a neighborhood and say, in this group of 10 houses, these are the 3 people that are likely to be uninsured. So they're going to be doing very focused campaign-like efforts and actual precinct areas where they're actually having people go door to door to talk to people about health coverage. Very, very focused effort. On a national level, the Robert Wood Johnson Foundation has put up $10 million to support their work, but it's $10 million in matching dollars. So states that put in money can actually draw down those dollars for their efforts. So this is one opportunity for funders right now. My understanding is that $5 million of those dollars have already been taken by states, so we have $5 million left right now that we could take advantage of if we wanted to. They are targeting Arizona as one of the states that they want to focus on. The federal government's also targeting Arizona as one of the states they want to focus on. And that's simply because, unfortunately, we have a large number of uninsured who are eligible for either Medicaid or through the exchange. So basically, there's lots of opportunity here.
May I?
Just a recommendation,
Sure.
and I didn't see it on one of your boxes, but
Sure.
another area for outreach would be a faith-based approach.
You know, I'm glad you brought that up. We actually are incorporating that through the older adult outreach.
Okay.
So Valley Interfaith Project is part of that, and we're doing work through the Arizona Ecumenical Council also. But if you have other approaches within that, I mean, all of this is like, if you want to help, great. None of this is rigid, so.
Okay.
But you're right, the faith-based approaches are also very important. So again, Enroll America is targeting Arizona for its efforts. They've hired, 3 staff so far, and they are looking to hire 7 more in Arizona. And they've drawn out sort of a campaign plan of what their efforts would look like in Arizona. So if funders are interested, we can share more information about what that looks like. Their goal is to actually reach about 600,000 individuals through this door-to-door canvassing, and to have about 111 conversations one-on-one with individuals. So it's really, it's a campaign.
A lot of volunteers.
A lot of volunteers. It's like a campaign. And in fact, the first head of Enroll America, the CEO was the former health policy person for Families USA, and their current president was one of the lead organizers for the Obama campaign. So it's very campaign-like. So if folks are interested in it, this is an opportunity. And this gives you a little bit idea of what Enroll America is. If this is sort of their ideal situation of what they're trying to do here, what the expenses would look like to have a full-fledged campaign to reach the numbers that I just referred to. So they're looking at a campaign cost of about $1.4 million. And again, the matching dollars could be used for this. So this would be an opportunity for funders if they so chose.
Oh, this just is this just for Arizona?
Just Arizona.
Okay.
Yeah. So again, this is an area where if funders, are interested, you can plug into that.
It's a good question about the healthcare marketplace.
Yeah.
The reason it's on my mind is when I was driving over here, literally before getting to the building, they were talking about quotes for premiums going down, and they were citing states already where it was projected that the cost for insurance would be less. And then they said it depended on the state, and it depended on the place within the state. And I'm wondering if you had any sense of what
What's going to happen in Arizona?
yeah, well, and then also what drives it, because one of the things that I think people will be moved by is transparency and how it affects them, obviously, directly, individually. And some things will still affect people in terms of their net wealth. What is it cheaper to not be insured?
Right.
And they'll do a cost-benefit analysis.
Right.
And they'll pay the penalty. They won't be insured
Right.
because they're healthy and they don't care, and they'll pay the $95 penalty in 2015,
Right.
whatever. So what do you think? Do you think it'll be competitive, or do you think it'll be better than nothing? Or Medicaid or Medicare will still be the best option for some people?
Well, I think it's going to depend on your individual circumstance. I think in general, what they're trying to do through the health insurance exchange and just reform in general is trying to sort of, again,
Spread the
pool
cost.
risk and spread the cost. And so, for example, if I'm a young adult, I'm probably, my premium will probably cost more than it would prior to health reform. However, I'd be getting subsidies to be able to actually purchase that, so that will help. And then there'll be availability of a catastrophic plan on the exchange that has sort of bare bones coverage. If I'm a woman, I probably will do better under health reform than a male. If I'm an older adult with lots of chronic conditions, I will probably most definitely do better under health reform, because there will no longer be able to be sort of discrimination based on your health status. When you hear about geography, there are certain, when you purchase health coverage on the exchange, there are certain factors that still can be used to be able to rate you differently. One of which is where you live.
But also age and gender.
Not gender anymore.
Not gender anymore. Okay.
There still can be differences in price based on age, but there are basically limits on how much they can charge you if you're an older adult versus a younger adult. So they can't charge you, I think it's 3 times, they can only charge you up to 3 times more as an older adult than a young adult, which is actually better than you probably can
So
get
for
today.
gender differentials where you might have a woman who, for 40 years of her life, is charged double the amount of insurance because she's a woman right now.
Right.
And when she hits age 50, finally her insurance is cheaper than a man's because men die of heart attacks at 50 and women keep going.
Well, and women tend to be, yeah, women tend to get charged more because they have babies, basically.
But their whole lives,
Traditionally, right.
whether they're having kids
Right.
for
Right.
40 years or
Right.
not, they
Right.
keep getting charged a higher rate. So gender can't be taken into account, they
Right.
can still look at age as a
Right.
factor.
And the biggest thing is that your pre-existing conditions can no longer affect
Whether you're even eligible.
whether you're eligible or how much you're charged. So beginning in 2014, if you have asthma, or even something as simple as asthma, right now you can be charged a lot more for your coverage. They can no longer take that into effect in terms of charging you.
So for a young person like that targeted group you're going after, who doesn't want to do it, or
Right.
doesn't care,
Right.
and pays the penalties
Right.
don't go into effect until 2015 for an individual's.
No, 2014 for the individual,
For the individual.
it's the businesses, that's 2015.
So the penalty might be $95
Yeah, it's
or
very minimal,
$100.
right.
How do you get that person to care?
Yeah, the value proposition is going to be a big
They'll
question.
care when they break their leg
Yeah.
or they're skateboarding and they.
And that's really, I think, part of the education challenge is that it has to be about more than just looking at the cost-benefit analysis. You have to be looking at insurance as something that protects you, right?
Well-care, preventative, all of those.
Yeah, all of those things, you know, getting care to prevent, to keep you healthy, to prevent against those catastrophic events that might happen in your life that could be devastating. And it's also part of a social contract, you know, the idea that I'm getting coverage today that's helping and helping a system that will care for me when I'm older and support that system. So all of those things go into
And
it.
the kids could still be on their parents' insurance till age 26.
So the age of 26, yes. But of course, a lot of young adults don't have parents with coverage to begin with, so that isn't the only safeguard. I mean, there will definitely be young adults who will have to get coverage through the exchange, so.
The group that's still the most troubling to me is the one that you mentioned, of non-citizens, because whether they're able to pay or not, it would still mean would they still be eligible to shop in the marketplace?
They
even
are,
if they're not
if you're
required
not,
to?
if you're legally present, you can get a subsidy and get coverage through the exchange, which is a big difference than what we have today.
Right.
So that's a big difference.
But you just-
But of course, if you're undocumented, you can't get coverage through the exchange.
Which means you'll still get sick, you'll still go to hospital emergency rooms, you'll
It is.
still need to be
It
treated.
is.
And instead of, even if you're able to pay a premium or
Yeah.
participate in the system and could subsidize your care,
Yeah.
we're not allowing you to do that. We're
Yeah.
instead going to make you pay whatever the exorbitant non-insured rate would be
Yeah.
and make it the difference by paying
Yeah.
ourselves.
Now, you remember the video that said about 10% of the population still be uninsured? That definitely includes that part of the population. So the health reform really does nothing to address that issue.
That's hard.
Yeah.
It just seems so ridiculous.
Well, you know, I think we all know better than anybody the politics around how you provide care to the undocumented.
That's one of the things people
Not
point to
small.
all the time.
Yeah.
We're tired of paying for those people, they go to the emergency rooms, they don't contribute, and so even if they're paying property
Yeah.
tax, sales tax,
Yeah.
tax, all these other things, social security tax, they can't even
Yeah.
redeem.
Yeah.
Then when they actually can pay for something and want to,
Yeah,
and we want them to defray those costs, they're not allowed to.
you're right.
It's just
No,
counterintuitive.
I agree, but, you know, it's, I think that, my take is that the health reform, well, what I often say is the health reform law, like our organization has never endorsed the health reform law. We just see it as a series of opportunities to do some really good things, issues that we care about. But is it perfect? No.
It's a start.
It's a start.
It's a start, yeah.
Hopefully,
Yeah.
but we're reverting back to the original concept in a country that believed in insurance,
Yeah.
that, or community benefits.
Right.
So that if I put in a pot of a certain amount of money,
Right.
and everybody at the table puts in the same
Right.
in our community, and
Right.
I don't get sick, I'm
Right.
grateful,
Right.
that I didn't get sick and I'm glad to pay for anybody at the table.
Yeah, I often talk about, my grandfather used to sell insurance, and when he would explain what insurance was, it was the idea of we all sharing in the risk, essentially, of caring for one another.
Faith-based
And he was definitely fell into that category also. And more and more, I think insurance over the years has evolved into trying to keep you out of the system as
So they can
opposed
build
into
big
the
buildings.
system. And so it really is moving back to the idea that we all are in this together, and how do we sort of make sure that we, as a society, make sure we all get access to care.
And for people who are enrolling, just from a tactical standpoint, they're enrolling in insurance on a rolling basis. October 1st, they'll be able to begin enrolling and looking at product offerings in the marketplace.
Right.
Will they become effective then?
It'll be effective January 1st.
Effective January 1st. So even if they enroll, they're not actually covered until the 1st of the
Not
year.
until January 1st, yeah.
It is coming fast, but just making me wonder if the rates will change or if you'll be locked in.
We will not know the rates for Arizona for some time. You may have seen, like the New York Times reported, New York, for example, the rates have gone way down. California, they've been looking pretty good. I don't know how it'll affect Arizona at this point. I think, you have to wait and see, honestly, so. So let me talk a little bit about where the federal government is putting resources in terms of all of this outreach and enrollment assistance efforts. So, like I said before, they seem to be putting money into media. So it's coming. I don't know how much, but they tell me it's a lot, so that's all I know. So we think that media is going to be taken care of, at least in terms of the big media push. Again, there may be some local media efforts that may be needed, but lots of resources being put into that area. The next area has to do with outreach, so reaching those specific groups. And so some of the things we know the feds are doing is, we know, for example, they have those 2 websites that I referred to before for materials, and that's no small thing. They're also working with some national partners to do outreach. I just learned today that they're going to have a partnership through the NBA to actually, get the word out. And they're having partnerships with pharmacies where they're actually going to be doing some outreach within pharmacy settings. So those are 2 examples of some of the outreach that they're doing. The next area is enrollment assistance, and this is really where you would have people basically helping folks do very focused hand-holding, essentially, to fill out applications and choose among competing health plans. And this is the area where we think that the feds are investing some resources, but it's really inadequate. And one of the reasons it's inadequate is, I think the federal government, when the health reform law was created, never anticipated that there would be all of these federally run exchanges. So there just was not money put into the health reform law for this effort. And so the amount of resources going into enrollment assistance is incredibly inadequate. So what we do know is the feds have released an opportunity for funding for what are called navigators, which are sort of paid enrollment assisters who can sort of do that hand-holding. Those grants were due at the beginning of June, and the awards will be made in August. But the whole dollar amount of those awards is $1.5 million, which, if you think about how much
the whole state?
for the state,
Oh.
1.5 million for the state. But if you think about, let's say a person doing that work is between $50,000 and $100,000, that's not a lot of people. It's like between 10 and 20 people for the whole state. So it's not a lot of money. We also know that the community health centers were awarded about $2 million to do outreach and enrollment assistance. So it's a little bit more, but again, we think it's probably inadequate. There have been some studies by some consulting firms in other states that of sort of similar size, estimating that for consumer assistance, you need probably somewhere between $5 and $15 million invested. So we think it's just not enough. And then finally, evaluation. We really don't know what the feds are doing. So let me back up to, again, to this flow chart and finish describing the different components of what Cover Arizona is doing. So I talked a little bit about the outreach efforts, both the demographic and geographic, and then the targeted efforts like Enroll America is doing. So the next really important part of a campaign effort is this enrollment assistance piece. And again, this is, I think, one of the areas where we're most concerned that there's not enough dollars. So there are two types of enrollment assistance in general, envisioned through the health insurance marketplace. The first are these navigators, and the second are folks who are called certified enrollment assisters. And really they're almost the same thing. They're basically people who help people fill out, you know, choose health coverage and fill out the
Where are they
application.
located? Where will they be?
We don't know yet. The navigators haven't been chosen, and they'll be chosen in August. And the certified enrollment, well, let me explain. The difference between navigators and certified enrollment assisters is whether the federal government's paying for it or not. So navigators are the people that the feds will pay. Certified enrollment assisters are people basically who go through some sort of federal training and get certified, but the feds won't pay anything for it.
So an agency might have someone who they send off to complete training because they have this population.
Exactly. And they get enrollment assistance. What the feds are talking about, and we haven't seen it yet, is both navigators and certified enrollment assisters will receive training through basically some sort of online training, a webinar of some sort. I think it's somewhere around 30 hours. The difference, the navigators will be probably going through a higher level of training than certified enrollment assisters. But it's still very vague. I mean, we haven't seen training, none of that's been developed yet. And then the final component of sort of thinking about, you know, how does this whole system work is you sort of have to have an evaluation component to all of this. Like, how the heck are we going to know if any of this is working or where it's working? So you need some of that in place also.
Kim, do we have many lessons learned from Massachusetts since, you know, in terms of how long it took them to enroll people? Because I think they have a pretty high enrollment rate at this point. But
They did. Yeah, there are lots of lessons from Massachusetts. You know, one of the things is we know enrollment assistance really matters. We know that people go to, they tend to go to some of the places that they've gone to in the past to be able to seek care. They don't change patterns of getting care overnight. So, for example, if you've been going to a community health center in the past, you're likely to continue to keep going to a community health center for a while. We know that enrollment in a shop was very, very slow, and in fact, it's still a bit slow. I mean, it took shop a long time to ramp up. So yeah, there are a lot of lessons from Massachusetts, but ultimately Massachusetts has also been a success story.
Yeah.
So let me talk a little bit about the last piece, that evaluation piece, because one of the opportunities also to pay attention to for funders is a new opportunity through the Robert Wood Johnson Foundation and the Urban Institute. They're actually creating something called the Health Reform Monitoring Survey, which is basically this quarterly survey that can be done to monitor what's happening with the Affordable Care Act. And it provides rapid feedback on what's happening in states related to Medicaid expansion and health insurance changes. And they're able to actually collect data and be able to report it on a quarterly cycle, very, very fast feedback. And the way they're doing this, it's actually really cool methodology. They're going to be doing quarterly internet-based surveys of a nationally representative sample of non-elderly adults ages 18 to 64. And the way they're able to make it representative is for low-income people who can't afford, you know, basically computer or internet. They actually buy them a computer and buy them the internet service to be able to have them complete this survey.
So if I'm not 64, I'm not elderly?
There you go. And they're beginning this, the baseline survey was conducted in the first quarter of 2013, and they're going to be doing, again, quarterly surveys, quarterly results, and the core questions address coverage and healthcare access and affordability questions. And they're going to get immediate feedback. And they're working, Robert Wood Johnson is working in tandem with the Urban Institute on this, and they're going to actually be able to do policy analysis and on what's happening in states, or happening nationally, I should say.
How big is the sample? Do you have any idea?
Yeah, I have that. I can get that for you if you want. It's I want to say like 900 or something nationally. And supplemental questions will be added each quarter to come up with more timely issues. Again, this is a partnership. What the opportunity for funders in Arizona is we can actually choose to augment the sample to be able to give us state-based results. So they'll be able to give us national results, but if we were to actually increase the sample size, we could get state-based results. And we also, there's some opportunities for additional funding to purchase basically add questions of interest to the analyses. So this is something, you know, if you're interested in, that I think is also really intriguing. The whole cost of just increasing the sample size to get state level data is about $150,000 a year, which is actually pretty cheap for data.
Especially here, we're sharing it costs.
Yeah, exactly. If we all like chipped in, it can be really cool. So
Data and reporting.
yeah, there's some additional costs for reporting. It's really the $150,000 is for the data. You'll get the core set of reporting. You just won't get sort of additional analyses. So let me sort of begin summarizing by talking about the timeline of what's ahead. So August, I talked about those navigator grants are going to be awarded. And there will also be a determination of which plans will participate in the exchange for Arizona. So we'll know more about who those folks are. We know that 7 plans have applied. How many are awarded, I don't know. August is when the HHS certifies and registers brokers related to the exchange. And August through September, navigators and certified enrollment assisters will be trained. October, open enrollment begins, and a media campaign begins driving people to the healthcare.gov. And then as of January 1st, 2014, coverage purchased through the exchange takes effect. We just recently learned that Access has said that they will actually start screening people for Medicaid expansion beginning October 1st also, which is great, because we were a little worried that people would be screened based on the old eligibility standards for Access beginning October 1st, and that would basically mess everything up. But Access is on board for screening for Medicaid expansion beginning October 1st. At the same time, people will be screened for the coverage through the exchange. So one of the things that as I look around and talk to other healthcare foundations across the country, it's really striking to me how many are putting in money for some of these strategies. So for example, I was talking to colleagues at the Missouri Health Foundation, and they were putting, and just so you know for context, Missouri is about the same size as Arizona. They've got about 6 million people.
Have they joined an exchange?
They're a federally facilitated exchange just like us. And but they don't have Medicaid expansion, so they actually have fewer people eligible for coverage than we would. And the Missouri Health Foundation is putting in $6 million for enrollment assistance alone. I mentioned Robert Wood Johnson is putting just $10 million match for Enroll America. And the California endowment, the California folks just freak me out every time I talk to them. They're like doing so much stuff. It's like, oh my God. I was on a call today with somebody from the California endowment, and they just like, oh my God, right, yeah. So I think it was like the California endowment put in something like $240 million for health reform implementation or something like that. But yeah. But today they said they were putting in $25 million just for Medicaid outreach, and that's just one foundation in California. And they have a state-based exchange, so other dollars are being put in towards the actual exchange outreach. So there's a lot of money going into this, and then I, start adding up that 2 million and 1.5 million for work that's to be done in Arizona. I thought, oh my goodness gracious. So there's definitely some opportunities. So let me just talk finally about where I think there are opportunities in general for funders and how you might help. So one is, supporting outreach. And, we talk about some of the targeted outreach efforts. I always like to talk about funders plugging in where you have relationships and where it makes sense to you, depending on what your interests are. So for example, if you work with older adults, maybe you plug into strategies related to outreach for older adults. That might make some sense. We think that there's, if you want to sort of engage in just a small way, it sounds silly, but there's real opportunities to put money into printing. The federal government's developed all these resources that are great on this website that you can download, and you can't really order any of those resources you can order like 25 per organization, so the amount of money devoted just to printing is pathetic, and so if you want to put some money into that, great. I talked about Enroll America, the idea of drawing down those RWJ dollars for the state and supporting their work. And Young Invincibles, another national organization. But certainly within those targeted demographic groups, either geographically or demographically, lots of different organizations that are doing good work. I just talked, for example, the other day to Area Agency on Aging, who's done fabulous work in the past, like with Medicare Part D. They're getting no money to do anything with older adults, and they certainly know how to do this kind of work. So, connecting with them, for example, might make sense. There are lots of different organizations that are working in those boxes that I talked about. And so if you have a relationship with like a Children's Action Alliance or a community health center or whomever, talking to them about how you can be supportive would be great. Supporting enrollment assistance. Again, I think this is the area that's most underfunded, and I can say SLHI, this is where we're dedicating most of our resources. What you want to think about is who's good at this kind of work. Because I don't know about you, but the idea of filling out insurance forms sounds painful to me. It's like the idea of doing taxes. You could not get me to do that work for all the money in the world. I really would not like to do that work. So, finding people who are good at this and plugging into them makes sense. Recently, $1 million was awarded to Arizona for what are called the CHIPRA grants. This is basically kids care outreach. So thinking about those organizations that got the CHIPRA grants and funneling into those same organizations, because they obviously have the competencies to be able to do this kind of work, might make sense. There are a number of organizations in Arizona that are called Healthy Arizona Users. They basically work with access to do enrollment assistance for Medicaid and CHIP already. So they've been doing this work for years. They have the competency to do this kind of stuff. So sort of connecting with them and funding them makes sense. And then certainly others who are experienced helping with enrollment assistance. So, for example, the tax credits, the low-income tax credits. Right. All of those people have the kind of competencies you would want for this kind of work. And then, we also want to think about expanding consumer assistance to organizations that reach vulnerable populations, just because they have the relationships, right? We know that to do this kind of work, you have to have people that connect with people that they trust, right? So getting them the training and then supporting their work makes sense. And then finally, I talked about the Robert Wood Johnson Foundation evaluation opportunity. So that is sort of a big picture, I think, are the opportunities for funders. So, questions? Yeah?
That isn't so much as a funder, because I'm kind of trying to, we're a very small funder in the valley, but I'm trying to figure out some ways and put down some notes about some agencies that we work with that might work with some of these targeted groups that we might be able to support.
Right.
My question is from the standpoint of connecting people to resources, because you said that there's gonna be confusion on the ground here.
Right.
This thing kind of opens up. Has anyone thought about a role for community action? I mean, community information referral and AZ 211?
Yeah.
And full disclosure, I'm the president of the board, newly elected 2 weeks ago. 2 weeks ago. So
It's funny you say that because we just talked about that, I think, 2 days ago. We've already connected with Find Help Phoenix, which is through the county health department. And they've agreed to actually list on their website where enrollment assisters will be available. And so the next question was, how do we get training to 211 and community information referral? So that's definitely on the list of who we need to connect with. We also, through the behavioral health subgroup, have also talked about how do we get crisis lines trained, because those are also folks who are going to get called. So those are definitely the group of folks we want to reach through training of some sort. But yeah, that would be great. So if you have either ideas on how it would work or how we could work together to help make that happen, I'd love to talk to you about it.
well, I have a meeting with the CEO Monday, so we have a board meeting next week.
Yeah.
My first board meeting that I'll preside over, so.
Yeah, no, that would be great.
This will be a great thing for us
That
to
would be
really talk
fabulous.
about and start to figure out how we might be able
Yeah,
to,
yeah.
our organization can plug in to help support this.
Yeah, there are so many ways to think about how to conduct outreach. So, and even those targeted demographic groups, there's all sorts of subgroups within them. So just an example, when we met with the chronic disease folks, they, as well as the children's groups, they all said, how are we connected with docs, right? So all of a sudden we're meeting with Academy of Pediatrics, with the Arizona Medical Association, with the osteopaths, you know, how are we getting training to all the docs through all the different providers? I guess what is both exciting and really frightening is that the feds tell us that we're farther ahead than almost all the other states.
Wow.
Which makes you really scared because you're like, oh,
Saying
really?
we're lying.
Good to you.
Yeah.
Good job.
We did nothing but argue with them the states.
Right.
That's our preparation.
Are they just trying to make us feel good?
Yeah.
No, I don't think so. I was just on a call with funders today and
Just
they were
remember, they have no
explaining-
evaluation
Now, there are
capacity.
exceptions, and California is like light years ahead of everybody. I mean, there are definitely some states that are way, way ahead, but certainly among the federally facilitated exchange states, I think we're way ahead. But there are a lot of resources that just haven't been developed yet, which is, again, frustrating at this point. So like reaching out to, for example, the docs, we're like, oh, somebody must have like a video that you can go online, and we're like, nobody does.
Yeah.
So it's a lot of work to do, But
It's so worth it.
Like the American Medical Association probably needs to.
Yeah, but
Well,
they're-
you would
they're
think,
hunkering
right?
down, wondering how they're gonna get
I
paid.
mean, we ended up contacting CMS and they said something's on the way, so you're like, all right. But in the meantime, we've got to do something in the interim. So there's a lot of work to be done. But I think, on the positive side, I have great belief that Arizona has the ability to roll up its sleeves and work together, to get really good things done, because we do it all the time with no money. So,
Well, I think people forgot that, even though before the most recent recession, so much of the mortgage crisis contributed to bankruptcies. Before that, the single largest reason for bankruptcy filings was medical expenses. And so that meant the system was not working for a huge number of people.
Right.
They could work their whole
Yeah.
life and then
yeah.
have a lien against their house or whatever, or lose their house because of those expenses.
Yeah, and so coverage is more than just access to healthcare, it's also an economic stability
For every other part of the
issue.
economy.
Yeah, it is. So. Any other questions?
One follow-up question. So after I talk to Catherine next week, who should we contact with to talk about the
You
role
can
of
contact me or this piece of paper here has, if you were looking at plugging into a specific kind of group, it has contact information for all of those groups. So you can just say, you heard my presentation, you're interested in doing work on outreach for older adults, and you contact Spencer, and you're in. And all of the regional coalitions, if you want to be on the monthly calls, all you have to do is email the person and say, I want to be on the list, and you'll be plugged in.
Thank you.
Thank you. So if you have interest in any of this or want to follow up, please give me a call. My email is also on here.
Great.